Welcome, good morning, welcome back to iCAAD Day 2. My name is still Christophe Saravan, and I'm still the Academic Director of iCAAD. I hope you're back in a great shape after yesterday. So we don't need to extend the topic of the day to conference fatigue, maybe. As far as concerned, maybe I should book myself with you after your conference and try to sort myself. Thank you. That'll be most helpful. It's an important topic, and a few hours ago I was just thinking about all that, and I look at the program we have, which is an amazing program, I believe, but that's the only session we're not talking about others, right? That's the only session we're talking about ourselves, as clinicians, I mean. It's amazing, and thank God we have this session today. It's commonplace to say that relapses are high in addiction counseling, trauma, therapy world. It's true. It's also divorce, it's also burnout, it's also secondary PTSD. We're overexposed. So this is what it is about today. Maybe another notion also, thinking of your work, Jamie, that I'm starting to decipher what's going on in terms of compassionate fatigue with some of my clients who are overexposed to human beings. So there's also something there, probably. So compassionate fatigue and provider resilience, hopefully, is the theme of the day. Jamie, glad to meet you. We never met. I know Michael Genovese pretty well. I know Max Cohen. I really value them. So you family here, welcome. A word about you. You're the CEO of Sierra Tucson Treatment Center in Arizona. But you're here speaking in your capacity of a specialist, an international speaker about compassionate fatigue. And I want to mention something that really struck me. I had a previous life in finance and business, and I understood that you had a previous life in HR as a senior executive. So many things became clear when I became a clinician about my past life, and I stayed a clinician, didn't go back there. I really believe there are bridges to be built around human organization. It's labor to be together in a room and to work. It creates fatigue at the end, so there might be food for thought there as well. So a very warm welcome, and the floor is yours. Thank you, Jamie. Thank you.
Well, good morning, everyone. My name is Jaime Vinck, and I have the honor and privilege of being the CEO at Sierra Tucson. I am also a licensed professional counselor in the state of Arizona, specializing in working with families that struggle with substance use disorder and mental illness. My career has taken a couple of different turns. The first one being out of the business world and human resources and into a helping professional, as I mentioned, a licensed professional counselor. Throughout the years as an LPC, I have managed large clinical teams, and now, as I mentioned, I'm managing a large team of clinicians, medical providers, business people, all sorts of different folks. Throughout the past several years, I have developed a passion for understanding why we do what we do and how to keep one another healthy, and also how to keep an organization healthy. Because as we all know, we can take the fish out of the toxic water and we can wash the fish off, but if we put the fish back in toxic water, you know what will happen. So what I'm going to be talking about today also will pertain to organizations and keeping organizations healthy. I love this quote that's behind me, that the expectation that we can be immersed in suffering and loss daily and not touched by this is as unrealistic as expecting to be able to walk through water without getting wet. So today the goals for our time together will be to look at how our work impacts our lives, understand the elements of compassion fatigue, how do we build provider resilience to get tools for that, to embrace the notion of our own compassion satisfaction, and finally, talk about some solutions for ourselves as clinicians and also for organizations. Sound good?
Yeah.
All right. I'd like to start out with asking all of you to get real with me for a moment here. Who'd like to share a negative way that your work has impacted your life? Yes, sir.
Inability to switch off. I love my job.
Okay.
It's constantly.
Oh, thank you.
Sorry. Inability to switch off. So I love my work. I work directly with clients with mental illness and trauma and addictions. And it's a double-edged sword. Because I love my job so much and it has so much meaning, then I attach a great deal of importance to it.
Okay.
So the switching off is actually harder when if I'm doing a job I don't care about, it's less stressful, if you know what I mean.
I understand
So
that.
and things like sleeping and mindfulness and having to do that. So yeah, that's
Okay.
That's how.
Can't shut it off. Who else? Thank you. Yes.
I can think of a number of situations with a particular client who was quite traumatized or is quite traumatized, and a lot of negative emotions living in me way after the session and going into my weekends and going into my evenings with my family, where I just felt distracted and a bit drained.
Okay. Thank you. Who else?
Good morning.
Good morning.
One negative aspect of my job, and I think in this field in general, is being on call 24/7.
Okay.
So getting calls after hours, getting calls at night and on weekends, and sometimes they're lengthy calls and require a lot of follow-up, and it's really difficult to have a work-life balance.
Okay. Thank you. Anyone else care to share? Yes. Oh, okay, we've got some in the back, then we'll come back up here.
The sorrow of losing a patient?
Oh, absolutely. Thank you.
Hi, I'm a police doctor, and I suppose the most negative aspect of my work is that we don't share the same values, i.e. that the medical profession is there to care and look after people, where the police are focused very much on capturing the villain of the piece.
Okay.
I find this most stressful when I'm dealing with the victims of rape, who often do not want to be intimately examined and withdraw consent, and then this causes huge problems with the police, who then get very angry with me because they see me as thwarting their investigation rather than respecting the patient's wishes.
Okay.
And I'm afraid this has led to me sort of wanting to just switch off when I get home, so it's impacted on family life. I found that I was drinking more than I should, so I've had to stop drinking. Difficulty turning off, switching off, it's become very, very stressful indeed.
Okay. Thank you. Got time for one more. Anyone else care to share? Okay. Well, thank you to those of you that did. And you'll notice certain similarities in terms of what people shared, is that it's very difficult to create boundaries and to leave our patients in their lives and go home to our own. So we'll talk about that today and come up with some solutions. So to those of you that shared, thank you very much. Between 40 and 85% of those of us that are helping professionals develop vicarious trauma, compassion fatigue, or high rates of traumatic symptoms, and this is according to one of our compassion fatigue experts. 70% of all social workers have exhibited at least one symptom of secondary traumatic stress. 70% of all therapists that work with sexual assault develop some sort of symptom of vicarious trauma. I found this very interesting because those of us that work in the addiction field, we know it's very common to run across a sexual assault, and that leaves 70% of us with vicarious trauma. So we're going to spend some time this morning talking about the definitions. What are the proper definitions of compassion fatigue? What we understand compassion fatigue to be is emotional and physical exhaustion and the gradual erosion of all things that keep us connected to others. And those things specifically are empathy, hope, and compassion. Figley defines compassion fatigue as the combination of secondary traumatic stress plus burnout. I wanted to take a moment and dig a little bit deeper into each one of these definitions, because I believe it's really important that we understand them individually and also collectively. And that way we know not only what the symptoms are, but how to get into the solution. So secondary traumatic stress, the emotional duress that happens when an individual hears about the firsthand trauma of another. The symptoms of secondary traumatic stress do mirror that of PTSD, and they include having difficulty sleeping, flashbacks of the stressful event, and avoidance. Something I wanted to dig into in terms of secondary traumatic stress is, as clinicians, we have a responsibility for how we speak and also how we communicate our cases. As we mentioned, I work in a rather large treatment facility, and we staff cases several times a day. What I notice with some of our clinicians that perhaps are struggling with some compassion fatigue is that they go into the details of each case, replaying what they said, replaying what the client said in a way that is not necessary, unnecessary shares. And what I find is that some of the details that they share can be quite triggering to others in the room. So I feel that we get to be mindful of what we're saying in a group. We also, as a trauma-informed center, we're very mindful of expressions that we use. And I'll give you an example. The expression committed suicide is quite offensive and triggering to some, rather than died by suicide. The other thing that we talk about when we have small groups to discuss these kinds of things are gestures. When we gesture anything regarding a gun, I wish our president in America was at some of my small healing groups, but that is highly offensive and highly triggering to some that may have some secondary traumatic stress around the event. I'm sure we can all think of a number of things that we find personally triggering to us. Mine is anything regarding horses. I am a huge fan of horses, very involved with them. So you can imagine if someone uses the tired, and to me, offensive expression, oh, let's not beat a dead you-know-what. I'm not kidding you. My responses are visceral because I have some pretty significant traumatic stress around the death of some beloved horses in my life. And so it's incumbent upon me to tell the people with whom I work, I would prefer that you not use that expression. And if you use that expression around me, I'm going to take care of myself and I'm going to leave the room, regardless of what it is, regardless of what the encounter is. And I really encourage all of you to think about, what do you find triggering and how do you get to take care of yourself by telling those with whom you work what you find triggering. The last time I did this presentation, I was in Colorado at the Addiction Symposium, and I had a therapist come and speak to me after, and she told me that the expression rule of thumb is extremely triggering to domestic violence victims. I didn't know that. And it's because in the olden days, you were allowed to beat your spouse with a stick that as long as it was thinner than your thumb. But she thanked me for bringing this into the space because she said she really now had the voice to tell people, please don't use that around me. It's triggering. So I invite you to all think about that when you take care of yourselves. Vicarious trauma is another really interesting one. This is not the worst thing you've ever heard. These are the thousands of things that you may have heard throughout your practice, the accumulation of the stories and of the pain. And what happens with vicarious trauma, it's very interesting, is that this is These are the shifts in our cognitive view of the world. This is the way we experience the world around us begins to change when the stories just continue to build. This becomes extremely important in our relationships with our loved ones. And some of the things that I heard this morning about the inability to separate work from home life, those kinds of things are often because of vicarious trauma and how we're shifting the way that we view the world around us. Something that I heard of in terms of describing vicarious trauma that really resonated with me is the old story of the frog in the kettle, is that if you have boiling water and you pop a frog in the kettle, they will hop right out. If you put a frog in a pot of lukewarm water and turn up the heat, the frog will just lie there and die. So to me, this was a very good descriptor of vicarious trauma and how we get to take care of ourselves and really understand when we are experiencing those shifts in the way that we view the world, our relationships, and most importantly, ourselves. So some symptoms of vicarious trauma that I wanted to be sure that we can identify is our self-capacities, the ability to identify our relatedness, the abilities, as we mentioned earlier, to conduct our primary relationships, our self-esteem, and the ability to tolerate and to integrate. What I've seen also with people that are suffering from vicarious trauma is that things from our past that previously had been integrated into our lives and we thought were pretty well dealt with, they can pop up again during times that we're experiencing vicarious trauma. Dysregulation and the loss of the ability to self-soothe. When we're going around like this in a state of hyperarousal, it's very difficult not only to soothe ourselves, but not to mirror what we're seeing in our clients, and then we continue to roll in a state of hypervigilance and dysregulation. Increased self-criticism and the inability to respond to the needs of others or seek support for ourselves. Next, I wanted to talk about burnout. Burnout is typically assigned to organizations, and it's a psychological symptom of emotional exhaustion, depersonalization, and reduced personal accomplishment. Organizations can become burnt out. We've seen it. Organizations can also suffer from vicarious trauma. In organizations that are burnt out, what we see is a workforce that are extremely depleted, overextended, fatigued, cynical. That depersonalization, the negative and cynical attitude towards the people that we are treating, and also reduced personal accomplishment, starting to believe that we can't make a difference. I've heard that before when someone will come, bless you, when someone will come back to treatment for perhaps the second or third time. Well, what's going to be different this time? How come we're doing this? You know, that sort of thing, the loss of hope. The other thing that happens in organizations that are experiencing vicarious trauma and also burnout is when there is an issue, when something happens. I know when you mentioned losing a patient, when an organization finds out that someone that had gone through treatment had lost their life, or even worse, if there's ever a sentinel event at an organization. That's when organizations are at extreme high risk for vicarious trauma and also as a whole, the burnout. And what we can do with that is looking at this definition, the condition of perceived demands outweighing perceived resources, getting those things in alignment as an organization and also as individuals, so we're not demanding things of ourselves that just are not possible. So the predictive factors of burnout are large caseloads, more work than can be accomplished, internal politics, perception of a lack of control, preponderance of administrative duties, lack of specific training for assigned work, treatment of those with personality disorders or malingerers, and difficulty with the work-life balance. So for those of us that work in organizations and also private practice practitioners, these are things to be mindful of and how they're impacting us in our lives. Because as we mentioned when we first started, when the burnout, when the traumatization, when those combine, that's when we're at the most risk for compassion fatigue. So the key differences in the definitions is compassion fatigue are the profound emotional and physical erosion when we just can't refuel. Secondary traumatic stress is when we bear witness to a traumatic event which can lead to PTSD. And vicarious trauma is transformation of our worldview due to the cumulative exposure to traumatic images and story. And burnout is often the stress and frustration caused by our workplace. So something that has been interesting to me in doing my research, is that I've learned that the people that are at the greatest risk for compassion fatigue and vicarious trauma are those of us who are the most empathetic, who do not see self-care as a priority, and those with a personal history of trauma. I found this compelling and also a little bit scary, just because I know in my work as a clinician, these are the things that make me good. These are the things that make me powerful when I sit down with face-to-face with a client and am able to access their pain. And so these are very important points to be mindful of when we think about who's at risk. So in terms of our own internal source factors, we look at the fact that we bring a past and a present to anything that we do, and our own ability to handle our countertransference really does take into account how well our life events are integrated into our story, and when we see things popping up from our past. It's very important that we stay mindful of that. Also, our internal schemas, our belief, what stigmas we may still hold from our past or our present. And also our social support systems, what's going on in our world, both positively and negatively. This can impact our internal source factors. Our own history of trauma, illness in ourselves and in our family, and our families and our relationships. Those are very important. Something that I wanted to also highlight is the economic situation. This can be a huge internal source factor. Who in the room deals with high socioeconomic status clients? Okay, a lot of us. Let's face it, none of us are in this for the money, are we? Would anyone like to share, have you ever been annoyed by one of your high socioeconomic status clients because they take it for granted? It's very important that we understand our own relationship with money, and we understand when we're coming from a place of scarcity rather than a place of abundance, and that we're able to regulate and to really be in gratitude when we work with high socioeconomic folks, or it can be triggering. I wanted to share a story of when I was clinical director in my previous treatment center, and I knew that one of our clinicians, very, very talented clinicians, was going through a personal bankruptcy. This was back in the States in the subprime days when the bottom fell out, and a lot of people were losing their homes and things were not good. And part of his role for that day was to confront one of our clients because that month she had spent $37,000 on her Amex by ordering things online. She was able to get into her account and order a number of things. So he had the presence of mind to come to me and say, I can't have this conversation, Jamie. This is something that I find enormously triggering. And so I stepped in and was able to have that conversation for him. So that's an example of what we can do to take care of ourselves and to take care of one another, and to know that it's really okay to have these conversations and to be able to say, this isn't comfortable for me right now, and I'm triggered for a variety of different reasons. So compassion fatigue can be recognized on the job by its effects on work performance, morale, behavior, and relationships. So we can see this in our colleagues, and we can certainly see this in ourselves. And as leaders in organizations, we, I believe, are ethically responsible for having this dialogue and to be able to see this in our teams, on our teams, and to also address it. I don't know about you, but if one of my loved ones was going to treatment, I certainly wouldn't want them to work with a provider that was suffering from their own compassion fatigue. So how do we do this? We identify certain compassion fatigue markers. And the way that I like to think of these markers is exactly what we know, the evidence tells us what works in an integrative model of care. When we look at ourselves the same way that we look at our clients, mind, body, spirit, then the solutions become a bit more obvious. And so I also want to point out that when I talk about compassion fatigue, it's important that we think about it not to pathologize ourselves, but as an opportunity to grow. Because the last thing we all need is to think of ourselves as somehow wounded. This is an opportunity for growth. So cognitive markers, what do we have? We have the intuitive thoughts and disturbing memories, preoccupation with trauma, lowered concentration rates, disorientation, thoughts of self-harm, harm to others, or a reduced sense of safety. The reduced sense of safety is where we begin to see shades of the cognitive covert cognitive changes. Emotional markers, feelings of powerlessness, emotional roller coaster, anxiety or fear, feeling of depletion, anger, perhaps a bit of survivor's guilt, irritability, sadness, and numbness. So these are the emotional markers to be mindful of. Behavioral markers. When we're a bit impatient, a bit snappy, when we realize we can't sleep, when we're having nightmares, being accident prone, losing things, being rigid or inflexible, wanting to do everything the same way, and using ineffective or harmful self-care practices. These behaviors can often lead us into maladaptive coping strategies. Spiritual markers, we have a loss of hope, loss of purpose, anger at God, questioning poor religious beliefs, skepticism around religion, reduced joy and sense of purpose, and loss of our own compassion. Social markers, and it's interesting, I bolded this one as I was reviewing my notes last night, because this so often comes up in these rooms, that our private lives really suffer and our ability to connect. Decreased interest in emotional intimacy, mistrust, and isolation. Whenever I do this talk at Sierra Tucson, a number of our employees, our clinicians and our medical providers will both say they don't have a personal life because they have a difficult time connecting with those that aren't in the field. And as a tell on myself, I often share that if my husband makes a dinner date with us with a couple that, perhaps he met one way or another socially, God forbid, I find myself out to dinner with them and listening to them talk, and I think, oh, how you spend your time while I'm saving the world. And then I have to stop and interrupt myself and say, not fair. These people are balanced, Jamie, you're not. And so I got so many people when I share that sitting and nodding their heads saying, yes, I do that. I've become a bit of a behavioral health elitist. And that's something that can lead us right into isolation, because I can promise you with this other couple, I was not engaging or charming, because I was sitting there staring at my phone, thinking about how what I do is so much more important than their golf. And so these are a slippery slope, these behaviors, and I really want to be sure that this gets on our radar about social markers and the loneliness and how important it is to tend to our personal relationships. Somatic markers, and this is where we get into, again, thinking about our nervous system as well as the whole phenomenon of mirror neurons. That when we're thinking about somatic markers, shock, rapid heartbeat, breathing difficulty, this is when we are activated. And when we are activated, we are at risk for imprinting, for taking on a holographic marker of our client's trauma. And so it's important that we be able to regulate, that we be able to breathe, that we be able to have our nervous system in normal fluctuation rather than in hyperarousal. We know that we are not doing this when we're dizzy, when we're always exhausted, when we find ourselves getting sick all the time. This speaks to a nervous system that's stuck in overdrive. And it's very important that we learn how to regulate. We talked a bit about the effects of on our work performance. Decreased quality and quantity, low motivation, and the avoidance of tasks. I watch that in our teams. When it's time to give someone news that may not be the most easy news to give, I find people avoiding it. And I certainly know that in myself, that this is really an indicator that there's something not right when someone that's ordinarily a hard charger and takes care of business goes into avoidance. Increased mistakes, being perfectionistic, and obsessions about details. What can happen to all of our morale in a workplace is, and I talked about the demoralization, and we can feel as though we really are not helping. And so it's important that we attend to the organization and we attend to the morale of a work group, especially if there has been recent loss, if there has been something that's happened to one of our former clients where there's some vicarious trauma going on, and certainly that sense of loss. It's very important that we address the lack of appreciation and things that organizations may be experiencing in order to heal and to move on. We've been talking about the behavior. We understand how these things occur. And I wanted to rest for a moment before we move into the resiliency on the substance abuse. We know that in our field, maladaptive coping strategies are they're a reality. And so it's very important that we be able to understand in ourselves and to be able to trust one another enough to speak openly about when we're at risk for these things. So, I promise, that's the last we're going to talk about the definitions and what the symptoms, the markers, and those kinds of things. And now we're going to switch into the solution, because along about the first half of my own presentation, I really do feel like going to work at Trader Joe's or some Sprouts or some sort of other profession. But not to worry, there's hope in resiliency. And I know resiliency tends to be something that we talk about a lot with our clients, but it can really help us. A couple of years ago, I had the honor and privilege of going through the Air Force Leadership Resiliency Program. And it's interesting how this came to be. I was on an Air Force base in San Antonio, Texas, and these big, tough people had developed resiliency training for their leaders and also for their airmen, because in 1 year on this Air Force base, there were 80 people that died by suicide. you can imagine the ripple effect that that had in the family system, in that organization. And not only were they struggling collectively, but they were struggling individually. So they worked across all the branches of service to come up with the Airman Resilience Program and then also a Provider Resilience Program. And what they basically learned is that a person's inability to face fear and adversity with courage and the will to persevere and overcome. And this is the essence of their provider resilience. So how do we build provider resilience? We do this by agreeing that our resilience is a strength, not a pathology. If we have vicarious trauma, if we have compassion fatigue, we got there because we care. We got there because we all set an intention to make the world a better place. And it's very important that we say, okay, I'm here, but I can certainly get out of it because I have my wisdom, I have my empathy, and I have my personal story, and I am able to use it in order to catapult out of whatever I'm in. So if we think about our strengths, I like to think about a resiliency role model. And I've got a friend, and she was my friend from graduate school, and we practiced together. We still have an office to this day in Scottsdale, Arizona. And she lost her only son, an Iraq veteran, to suicide. And what she's done with her life is she has devoted her life to other parents and to other veterans so that they will not experience the same heartache. And she made a choice. And her choice was to wallow and to go down even deeper than she already had, or to utilize her resilience and to utilize her training and to devote the rest of her life to other families and veterans. So she is my resiliency role model. Who'd like to talk about theirs? Anyone have a resiliency role model? Someone that you look, yes ma'am.
I'm just trying to collect myself from what you were saying. I too have a friend who I was visiting 3 years ago whilst I was working in America. And the police arrived one night to tell her that her son had been found dead too. And she is extraordinary, the way she has doubled her spiritual and religious beliefs in how because she has 2 living children, adult children, one of whom is an extreme borderline personality disorder, which is actually more complicated. I just admire the way she just gets on with it. There is no self-pity. There is a real observance of how life is incredibly tough. She has not endless, because she does take care of herself, but she has a lot of time for other people, good works. She's involved with the local church, things that you don't usually associate with life today. So she has a kind of an eternal quality to her that I find very soothing.
So let me ask you a question. Prior to her loss, would you have thought about her as a resilient person?
No.
Okay.
No.
And so, my friend either. And so, a question that I believe is relevant to all of us is, how do we bottle that resilience, and how do we practice our resilience before there's a life-shattering loss? How do we make it who we are, and how we conduct ourselves?
I find that I often confuse endurance for resiliency.
Oh.
I'm very good at enduring, but I have to switch gears and make it resilience rather than endurance.
Well, I feel it's an occupational hazard.
Yeah.
Because we are in an endurance race, huh?
Yeah.
Thank you for that. Anyone else want to share about their resiliency role model? Yes, please.
I was thinking it's quite hard when you asked that question. I thought, but the people who I admire, I see them burn out. And I was thinking, God, what a hard question. And then when I was listening to that lady, I thought of one of my older school friends who her cancer wasn't diagnosed till it was stage 4, and it had gone from breast to bone to liver. And she's gone past the kind of expected that you're meant to live a certain time, and she counsels people who have stage 1 or 2. She raises money, she's written books, she's gone to the Arab world to teach Arab women how to look for lumps. She's inspirational, and I was thinking, that's my one, because when she doesn't, sometimes mutual friends who get cancer, and I think they're so self-indulgent, theirs can be treated, Lucy's is like that, and she doesn't judge, she's just but it was a really hard one because I couldn't think of anyone at first. I was just looking at all my work colleagues, and all I work in private practice and in an organisation, and I think, they've got their strengths, but God, we all get exhausted. So
Okay, thank you. Anyone else like to share of someone? Yes, please.
Hi, I think the first thought I had when you asked the question was just a multitude of different people, as opposed to necessarily one individual, ranging from my parents to people who I know in the industry. And I think the quality that I admire most in the two individuals in particular that I'm thinking of, both very, very successful, but they are both incredibly vulnerable. They're just, I consider myself extremely lucky to be good friends with them. And within that friendship is just a complete openness and admission of when things are difficult. And also humility in saying, I need some help now. Can I have some help? And also being able to recognise when perhaps I'm struggling and saying, do you need a bit of extra support this week? Right. So it's for me it's a lot of people, but it's that quality that I personally really value.
Okay, so what you're really describing though is the essence of the solution. The vulnerability, the humility, the ability to say, I do need some help, and also the confidence that we can say that to one another. But I can't say I'd ever heard anyone talk about vulnerability in one of these before, so thank you for that. I really, really treasure that. Any final shares? Yes, please.
My daughter.
Your daughter,
Yes.
okay.
Everything that's happened to her, thank you. Everything that's happened to her, she's got such an inner strength and humility, and is prepared to help her friends and her mother. And I just find it very inspiring.
Good. Well, thank you for that. And so the qualities that we heard is a certain openness, certainly strength, and then the humility, vulnerability. So those are things to think about when you're thinking about developing your own resiliency plan. So how do we build resiliency? By creating the ability to both self-soothe and self-confront during a stressful situation. So I found this really interesting, that when we self-soothe, it enables self-confrontation. And when we can work hard enough to do those simultaneously, we're building our own resiliency. So self-soothing, again, this goes back to the nervous system. We deliberately relax. We breathe. We meditate. We orient. We ground. And these are things that, they're portable. We all have the ability to do this regardless of where we are, regardless of what's going on right in front of us. We can self-soothe. Self-confront, a little tricky. This is the process of looking at our own anxiety and examining what might be learned from the situation. Providers ask themselves questions such as this. Why am I anxious? What's going on right now in my body? Am I depending on someone else to validate my sense of worth? What's the growth potential in this situation? Who am I trying to impress? What am I trying to fix? And what am I trying to prove? I'm going to do another little tattle on myself here. I mentioned my office in Scottsdale, Arizona. That's 2 hours from where I work and live. now in Tucson, Arizona. If I have and I have rather a big job when I work a lot, if I get a call from a former patient of mine that is 2 hours away and they say, I'm kind of struggling and I would like to see you, it has taken me 6 to 8 months to get to a point where I can self-confront enough to say, you know what, my partner in my private practice can attend to them right now, and I'm going to stay down here. I am not going to drive 2 hours and meet with this patient. That really just, I do that because on some level I need that. And on some level I'm trying to prove something, right? Maybe to myself that I'm the best therapist in all of America. I don't know. But the ability to self-confront and the ability to get real with myself allows growth potential. And then I can knock it off and take care of myself. I thought this was this was a revelation to me, and so I took it, put it into a chart. If we can't self-confront, if we can only self-soothe, Max, I'm sorry, I am standing right in front of you. That creates avoidancy. These are the folks in our lives, in our practice, in our organizations that are withdrawn. Or they're highly demanding. They're the emotional ones. They're also at times kind of a victim. Do you all know the drama triangle? Persecutor, rescuer, victim. They tend to be over on the victim side and stay there. Avoidance and the maladaptive coping strategy for the over self-soothers, overeating, and substance use disorder. On the other hand, we have folks that can't self-soothe. They can only self-confront. These are your negative Nancys, your agony Angelas in your workplace. These are the people that are stuck. They're in their anger, and they're going to show you exactly what to do. They're strident, and there's a failure to see the growth opportunity. And you notice how quickly I slipped into that mode? Because I can be a little bit self-confrontational as well. So that was a joke, in case anyone would like to. So that's what happens when we do one rather than the other. So right now, I would like to think for a moment on the work system and our fellow workers. Because if you look at this, we've got provider, that's us in the center. We've got the patient and their trauma, and they are in a line with us. If we look at our work system, that's something that we really get to evaluate. Is it healthy water for us to swim in? And if it's not healthy water, then don't imagine that you're going to be able to thrive while swimming in it. And then we look at our fellow workers, our colleagues, the people that really feed our souls. And this is such an important group to look at, because that is what keeps most of us doing what we're doing, because we make these very deep relationships with our colleagues, and there we find our support. So very important to look at not just our patients and their trauma, but to look at the other things that support us and hold us up and confront us, and to understand whether they're working for us in our lives or not. That takes us to my favorite topic, compassion satisfaction. How do we feel about our teams? How do we feel about our colleagues, our coworkers? Can we count on them? Can we count on them to tell us when we are being a little bit difficult, when they're seeing some of these markers? Can we also look at the positive aspects of our helping? Can we look at the pleasure and satisfaction that we derive from working in this system? And then these compassion satisfaction things may be related to the care in our system, the work with colleagues, our beliefs about ourselves, or our altruism. The compassion satisfaction is a key component to building our resilience, and it's important that we look at it and understand what it is. So there's a Oh, that one got out of line, so let me just, okay. So there is a test, an assessment that has been developed, and it was developed in the 90s, looking at, in the late 90s, after compassion fatigue was first identified. And it looks at 3 psychometric properties. And what this looks like is, looks at our compassion satisfaction, burnout, and secondary traumatic stress. And let me go back just to have a second. That's the link, and this would be in your handout, and I know that they're available online. So this is a very valuable website. Everything is free of charge, and this looks at all different components of our compassion fatigue. And if you take the ProQual, it gives you 3 different subscales so that you can look at how you're doing in each one of these areas. And if I can just come back to compassion satisfaction for a moment, this becomes essential in looking at whether we're thriving or just surviving. And so it's important that we're able to monitor our own monitor our own compassion satisfaction. So, believe it or not, there's an app for this. There's an app for everything. But this is something that was developed by the armed forces in the United States. And this is such an amazing thing. You can download it at no cost. And it's the Provider Resilience phone app. And I love this. We all use it where I work. And it holds you accountable. And let me walk you through it a bit. So it gives you your overall resilience rating. So you can assess where you are. The time since your last vacation, it monitors that. And it gives you a running total. And then it asks you at various different times to update it. So here's your vacation clock, so you know how long it's been. Your burnout. So it actually gives you can take that ProQual, the paper pencil test I just gave you the website for, you take it on this app, and then it gives you your scores in your compassion satisfaction, your burnout, and your secondary traumatic stress. And so then it keeps track of it, and you update it every 30 days. The other thing that's important about this is that it gives you solutions. It gives you resilience builders and killers for every day. So you can ask yourself, am I following my own plan? Am I holding myself accountable? Am I doing the things that will keep me healthy? And then it gives value cards and all different kinds of things to cue you to be doing what you need to do. The compassion satisfaction, I think this is really interesting here, because what it does is it tells you, okay, you may be burnt out, which means you may not be thrilled with your organization. You may have had some difficult clients, so this is a bit up. But you know you're still feeling good about what you're doing, and you're still feeling good about the support you're getting. So I love the holistic manner that this app supports. So I highly recommend utilizing it and making it part of your solution. Along those lines, building provider resilience, what we do with the app is it gives you different tips for looking physically, mentally, emotionally, and spiritually at your own renewal. So if we look at what skills, we've been talking about regulating our nervous system to be present in a healthy manner for a variety of reasons, and that begins with body awareness. Know when you are in your chair, when you are attending to someone in your office, that you're aware of what's going on in your own body. You know, if we're always doing this, we know all is not well. Setting your intentions. Why are you doing what you're doing? Evolving away from being reactive. And again, mission-driven and principle-based. And I highlight that just because being with a large organization, I find it my responsibility to state the mission of our facility over and over again so that the people that work there can have an intention. They can feel part of, and they know that they are on a mission. We are on a mission. And to have that mission be principle-based, we're there for the residents we treat and the people that love them. We are not necessarily driven by the almighty dollar, because that will not drive people to set intentions. Tolerance of pain for growth. Pain and suffering are a bit different, right? We can tolerate some pain. Suffering is when we attach meaning to the pain, and that's when we can really lose our way. And maturization of our spirituality. Along with having mature spirituality, I think it's very important too that we have the ability to perceive things in a mature manner. This is where some very old school cognitive behavioral abilities come into play. That we have choices versus demands. That we are resilient to judgment by our clients and peers. This can be very, very difficult when we're exhausted, but the ability to just take it if someone is not happy with what we're doing or the way we're doing it, and that can either be one of our peers or one of our clients, that to be able to not to attach too much meaning to it, and to be able to soothe and tell ourselves all is well, to let go of the outcomes. It's really not up to us whether people are successful in their recovery or not. And a balance of both potency and humility. The word humility came up when we talked. A lot of people brought it up in terms of resiliency. And I do think that humility is a very important quality when we look at building our own resilience. And then again, back to the connection and the support. Empower a few people to confront you. People that you trust, people that are in your trusted circle, to be able to say to you, things aren't going so great, I'm thinking, and how can we support you? The ability to tell on yourself, to be able to own when things aren't great, and be willing to own your own behaviors when you know that they're not healthy. The ability to show up as really you. Who is your authentic self? And are you bringing that authentic self to work with you every day? Accountability and the desire and the comfort to create and to share your own narrative. We're going to talk about that in our final slide when we talk about things that we can do. But it's part of your resiliency to understand your narrative and where you are in this process. Resilient skill 5 is self-care. And this is something that, we all know these things, don't we? Whether or not we do them is really up to us. But the research tells us that aerobic exercise 3 times a week, looking at our health, how often do we blow off our own medical appointments in order to see a client or in order to work, and we're not looking at our own health carefully enough? Engage in something that requires a lot of your mind, something that isn't behavioral health oriented, music, art, sports, something that you go all in on. And mine is horses. And if I'm on the back of a horse, I really cannot responsibly be thinking about something work related, or I'm going to end up not on the horse anymore. And so that is an all-consuming passion. And I highly recommend that you find what yours is as well. Diet and sleep, we know this, and be active about our self-care rather than passive. I wanted to switch into the ethics of self-care as long as we brought it up. I think it's very important that we think about our ethical practice and the active, deliberate, and creative approach to fulfilling ethical and legal responsibilities. I bring this up, and I mentioned that I spent a lot of years as a clinical director, and I also taught ethics in a master's program in Arizona. And what I found over and over again in spending time with folks on the Board of Behavioral Health is it's a slippery slope. When we're experiencing compassion fatigue, that's when we are the most vulnerable to make poor decisions and to have some ethical challenges. I love this. I nurture myself so I can nurture others. And oftentimes people don't think of ethical practice as good self-care because the first thing to go can be the documentation. But it's so important that we take good care in terms of our documentation. The best defense, ethically, is a good offense, no matter what, to always document the note when the session has concluded. And instead of thinking about the ways of get into trouble, focus how we can even be better at our practice, to continue to train, continue to grow, and to proactively manage any risk in your practice. Ethical pitfalls, these are things to which I believe we are the most vulnerable when we struggle with compassion fatigue, when we struggle with vicarious trauma. Boundaries, multiple relationships, dual relationships, social interactions, non-sexual touch, self-disclosure, and practicing outside of our area of competence. I wanted to speak on self-disclosure for a moment because when we're experiencing symptoms of depression, we're at a higher risk for inappropriate self-disclosure. And something that one of my professors taught me, and I've never forgotten it, is if you're tempted to self-disclose, think about, is this something that I could justify, that I could explain to my governing board how this benefited the patient if I'm sharing this information? And I've found that to be a very good way to regulate, and also something that we really think about in clinical supervision when we're seeing someone that is sharing too much of their own story. That can be a very good marker of a place to look. Dual relationships and multiple relationships and boundaries. Want to just touch on that for a moment. In the state of Arizona, what do you think the #1 board complaint is among therapists? Any ideas?
Knowing somebody in somebody else's environment, a family member or you've gone to.
That certainly comes up. Yes, Max. Yeah. Inappropriate sexual relations with a client. So that is something that we still see, and obviously those are therapists that are struggling a great deal, and it's something that even, dual relationships, when we're tired, it may be, we may not think so much to have our guard up, to have boundaries in terms of even entering into seeing a patient after treatment if we're not supposed to, those kinds of things. So I really wanted to be sure that when we're thinking about good self-care, we think about taking care of ourselves ethically. From an organizational standpoint, the things that are important for interventions that an organization can do is to give credit and reward a job well done. We celebrate every win where I work. I'm very, very passionate about bringing ice cream trucks to work. I've got one that's being delivered tomorrow. And, Max is laughing, but, that's something that people love that, and it's a job well done, and I have my own milestones where I know that we need to reward people. Foster an environment of dignity and respect. We have a group of people that talk about, how I mentioned the different phrases that people use that they can find offensive. There's a zillion of them. It's fascinating to me. If you put a group of 5 people together and say, what do you find offensive, and open up the dialogue, the things I've learned, it's so illuminating. And that really helps to foster the environment of dignity and respect, so that we're speaking to one another in a way that makes everyone comfortable. Be available to talk with subordinates. Front door, back door, whatever it is, the doors have always got to be open, so people, if they're having that moment and they know that they need to talk with someone, that you can be available. We just had one of our frontline clinical tech workers that had been struggling, and he came to me and he just said, Jamie, I'm not doing well. And so I took him, we went into my office with his direct supervisor, and within 48 hours, we had him on a plane to a sister facility. And he's there free of cost for 30 days. Why is that? Because he's part of the family, because my door is always open, and because we're supporting him. And we were able to get to him before things got completely out of control. And that's just what healthy organizations do. Keep staff informed. Communication is so important because we all know what people don't tell us, we make up, right? If someone isn't telling you what's going on, you are going to make it up. Allow sufficient recovery time. This is so important with therapists. If we know that they've had a difficult client, if we know that our docs really had someone that was a handful, don't give them the next one that comes in the door. Allow them time and space to breathe and to recover. And also to know what positions are the hot buttons. In our organization, our mood therapists, I'm telling you, they cannot be in that position for more than 18 months. We start to see the effects. And so to know which positions have a high rate of risk for vicarious trauma and compassion fatigue. Also, at all levels, have leadership acknowledge stress. What does it look like? And what does it mean? And also to do our own work so we're not running around with activated nervous systems. Because I promise you, the more that we are activated, the less likely someone's going to come into your office and say, hey, I need some help. And that's where it goes to set an example of self-care. So these are things that organizations can do to intervene and to create an environment where compassion fatigue is openly discussed. I like this Reaper model. So this is something that has been identified for organizations to look at in terms of dealing with compassion fatigue. Recognize signs and symptoms of it, and there's a lot of that information in this presentation for you. Education at all levels. This needs to be part of the vernacular in every level of the organization because everyone is vulnerable to compassion fatigue. Acceptance in the culture regarding empathy, that it's really okay to be empathetic no matter what your job is. In fact, I believe it's a job requirement. Permission to deal with symptoms openly, exploration to identify resources, and have referral sources when necessary. So I really like this way of organizing it. It was something that's credited to Mitchell and Bray. I believe as we go up in the organization and someone has supervisory responsibilities, that it's even more important that they understand the importance of this. And then in terms of organizational interventions, something that we're also doing at Sierra Tucson is we created healing groups. And what that does is it gives you your 3 to 4, and they're at 8 now, trusted colleagues with whom you can share what's going on with you in your work. And we meet over lunch once a month, and we are vulnerable, we are humble, and we talk about what's going on. Step 1 to these healing groups is that we did a trauma narrative. And to me, this is so important in our work, which is why I have all the details of what a trauma narrative is. And it's important that we be able to honestly own what's intruding into our thoughts and dreams, what's going on with us, and to journal about where do we think our vicarious trauma is showing up in our lives. At what point did we have a loss of innocence? Where did we start to get a tad bit jaded? Where are we feeling anger? Where are we feeling irritability? Have we had any times that we've been avoiding meetings? What client issues are we sick of hearing about? The predictability. Is there anything that we just would prefer not to hear over and over again? Avoiding difficult topics with clients. That's something that we talked about as a marker as well. But to be able to write it down, share it with your colleagues. Feeling discouraged about the lack of outcomes. That's got to be some options Outcomes, options, same thing. I mean, that's something that we all experience from time to time, and to be able to share it with one another that's like-minded, it has a very strong healing effect. Failure to get a life. I can't tell you, every time I do this talk, when I talk about my social life and I see this, I feel better. Just because we know we're not alone and that we all get to work on it together, and to own our fatigue and exhaustion. So I highly recommend that you do your trauma narrative on your compassion fatigue and share it with a few trusted colleagues, and then let the healing begin. The other thing I highly recommend is a personal resilience plan, and then utilize the app. So before we go to questions, I would like to ask you all, what wonderful ways has your work impacted your life? Because there are wonderful ways, right? Yes, please.
A sense of meaning and purpose, which drives me.
Okay.
And in spite of the pain, there are moments there are weeks when I have a turn of key in the car moment. Should I quit? Am I cut out for this? But all of that's compensated every now and again by one person turning around, which you can't quantify with money.
Absolutely not. Thank you. What other wonderful ways has your work impacted your life?
Now I'm retired now from working on treatment, but has been like a meaning of my life. Working.
Really?
Yeah.
Okay.
Definitely.
That's pretty. Everyone hear that? No. Life meaning. Could you say it again?
The meaning of my life, the work I've been doing for 22 years.
Mm-hmm. Life's meaning, very powerful. Thank you. Yes, we got another one.
I have really enjoyed the connection, the special connection I have with my patients.
Okay.
And that's very uplifting for me.
Mm-hmm.
And it gives me a lot of energy and hope and beauty. It's brought a lot of beauty.
Okay. Well, it's quite sacred, isn't it? To be, yeah.
Yes.
Thank
definitely.
you.
The creativity in the work, and the knowing that I have more courage than I realised, that I will go to those places and I'm contained enough to be. I didn't realise I had that ability. And when you are in that connection like that lady said, and the other is the enormous different parts of the human mind, when in the relationship, where mine had got lost in have opened up. So yeah, just huge windows.
It's beautiful. Yes, please.
Two things for me. The first is just every day in my workplace is inspiring to me, and that's because I have the opportunity to work with amazing, talented, skilled, passionate, creative individuals that are really dedicating their lives to helping others, and it's really amazing. So the team around me inspires me. The other thing is, I thought it was really interesting earlier when you asked who the resiliency role models were, that none of us chose our clients. And I think the opportunity is to really look at the resiliency of our clients and how inspirational that is, and just the opportunity that we have to be a part of those journeys is just something really beautiful.
Mm-hmm. Thank you for that. Absolutely.
Hi, good morning.
Good morning.
Excuse me. Firstly, I'd like to say I'm blessed to be here. Just being around so many beautiful people. Just the ambience and the atmosphere and everything is just wonderful, so I'm really blessed to be here. Thank you, very grateful. For me, just one thing really is just coming out of self. Doing the work that I do and coming out of self is probably the most rewarding part of what I do, because it's not about me anymore.
Thank you. It's beautiful. Any more wonderful ways that your work has impacted your lives? Yes, please.
Yeah, hi.
Oh, we have
yeah,
another one.
my work's impacted my life by it's just made me more confident in myself, basically.
Okay.
And yeah, I enjoy this job, like, because obviously I was once a client, and now I work. So yeah, it's done wonders for me. So yeah, that's all I like to say.
Congratulations.
This question is really amazing because earlier I shared about how my work can come into my personal life and that feels intrusive, which is true. But thinking about it now, that doing the work that I've done has informed and influenced me in my personal life so enormously. And so the ability to be compassionate with the people I love and to have an understanding and awareness and an insight into them as humans is without doubt something that this work has taught me, and that is without doubt the greatest gift.
Thank
you.
you.
The reward of that is huge.
Okay. Thanks so much. Anyone else care to share about the way this work has impacted them? Okay. Do we have any questions? No questions.
Sorry, it's just a practical question. Are we able to get a copy of your slides at all?
Oh, absolutely. Yes.
Okay, perfect. Thank you. Just because we move through everything so quickly, I found it such a rich experience. I'd just love to be able to have a copy of them to take them to colleagues.
Absolutely. Thank you. All right. Well, oh, yes, please.
Hi. As a as a leader in an organization like yourself and others in this room, I have a question about. There's this other side to the self-care where some staff can take it to this level of taking care of themselves, and it becomes a hindrance to their work.
Yes.
And how and their effectiveness as leaders of themselves, essentially, so that they can treat the client. And so there's a lot of work that they do on themselves, but how do you, maybe at Sierra Tucson or in your work, kind of balance that for them? Because there is a level that sometimes can be a hindrance to the work that they need to do with the client. That could be anything from shutting off their phone after hours when we might need them to keep their phones on, or other things that they might use as tools while they have taken kind of the compassion fatigue or resiliency to this other level of almost like shutting down. So how do you as a leader or how in your organization do you choose to kind of work on that with your staff so that there is a balance for them and to understand?
Well, that's a great question. And when I first started my job at 4:30, man, everyone ran to their cars. And it was like nothing I'd ever seen since I left the assembly plants in Detroit, And I said, whoa, the patients are still here. Why does everyone run to their car? And they said self-care. Like, okay, and I thought, I have boundaries, that's good self-care. And so I took a deep breath and said, I need to work on the culture here where self-care can become selfish, and to create a culture of trust where I could call them on it, and to be able to say, no, we run to our car. Perhaps we could walk to our cars, and we do that after everyone's tucked in for the night and the evening shift has started. So to be able to really create that open culture where self-care doesn't become a cop-out, because it can, I get that. And so I found that self-care had no container, and it wasn't attached to anything. And so since we've been talking about compassion fatigue and giving actual practice, if you will, to it, then we've been able to really put a limit on the self-care becoming selfish, if that makes sense. Thank you. It is tricky. And there's one in every crowd, someone's gonna, and then one becomes 5, right? when it's culturally approved behavior. But I also think, gosh, you've got me on a rant now. I also think that that's a sign of burnout, when everyone wants to get the heck out of there. And so now we find them more engaged and really buying in. So, yes, please.
Thank you so much for addressing the part of the cultural aspect to it, because one of the things that I've been thinking a lot about is something I see in my organization is the level of burnout and the compassion fatigue is commensurate with a low-grade sort of anxiety that goes across the organization that is really in response to the volatility of our field right now.
Yes.
In terms of, sometimes you have a very low census and then suddenly the census will explode, but everybody's afraid for their jobs, those types of things. And in my organization, when the census is low, like that anxiety gets, really heightened, but then it comes back, then the staff is burnt out, and it's crazy. So I feel like I'm constantly trying to balance the anxiety, of the staff, but I really feel like what's underneath it is that the burnout and the compassion fatigue. So I just wonder what at CR Tucson you do really as a culture to really kind of address that low-grade anxiety that's always there, at least in my organization. I don't know if in yours.
Oh, absolutely. And, we do work this program in terms of compassion fatigue, and it is part of what we talk about. And we're willing to own it, and people have a healing group. So if they want to talk about their anxiety and, again, what's underneath it, are they afraid that they're going to lose their jobs? And I think that's the fear that drives a lot of that low-level anxiety when census goes down in our business, and to make them comfortable that we will find a way. And I believe it's a lot about trust and leadership, that their heads aren't going to be on the block if census goes down, that they're not disposable.
Thank you.
Yes, please.
The healing groups, do they self-form? Do y'all put people together intentionally? Are they facilitated?
They are put together randomly. We draw names. And then I've identified leaders, including myself, that has a healing group. And when we walk in, I say the same thing that we say when we do groups with patients: confidentiality pledge, and nothing you say in here can be held against you, kind of thing. And we have to open more now because more people want to do them. Mm-hmm. But they are formed randomly. Any other questions? Yes, please.
Do you have any tips for people like me who work in private practice and I don't have any coworkers?
Absolutely. And I spent 6 months in private practice before that was what I was doing right before I started at CR Tucson. And I formed a group of my own of therapists, and I found that I just had to do that, because all of the things that were on the slides in terms of behavioral and emotional markers were occurring. So I highly encourage you to reach out in terms of forming a group with your colleagues. I don't know if you have a specialization, if that is a good way to do it. I know that in the States, the somatic experiencing practitioners, they have a very tight-knit group. And so in every state, you can find somatic experience practitioners that are like-minded, that want to form a group. And then another really good way is with the university. I found myself teaching, and that was another good way to form another group of colleagues, because the isolation can really be overwhelming. At least that's what I found it to be. So get creative about finding other folks. Any other questions?
Hello. I missed a couple of minutes of your presentation.
Yes,
you mentioned something about resilience and using an app.
Yes.
What was the app, please?
It is. I will go back there. And this is a provider resilience app that was developed by the American Armed Forces for everyone that works with providers. And they utilize the different psychometric markers that we talked about today, the psychometric properties of compassion, satisfaction, burnout, and stress. And then there's the holistic flavor to it, where it gives you mind, body, spirit tips. And it also calls you out on it with builders and killers. I wasn't sure about that word with all of my sensitivity that I'm plugging today, but I didn't develop it. Yes? 5 minutes? Okay.
Could you go back? I think it's 2 slides, the pro-qual.
The pro-qual, absolutely. This website for the pro-qual is just brilliant. There's so many resources. And it's kind of fun to do it pencil and paper or do it on the app, whatever you prefer. And when I do the big trainings for new employees, I will ask them to complete the pro-qual in advance and to bring it so we can dialogue around it and to know where we are. Well, thank you all so much for being here. And my final slide, I don't know if this made it over here for those of you from the States. Who remembers Jerry Springer? Not anyone I ever thought that I would quote in a presentation, but I love this. He always used to say, take good care of yourselves and each other. And that to me is just the essence of this morning. So thank you.